Hey everybody, I'm Stewart. I'm one of the joint replacement surgeons with OrthoVirginia here in Richmond, Virginia. And thanks for tuning in to our Facebook Live talk today. We've been doing these for a while now, every month or so, that are just supposed to be informative talks on different topics in orthopedics. And today we're going to talk about knees and knee replacement and just some of the things that patients like to ask about, a couple different topics that are, kind of in vogue right now that patients, ask me about in clinic and things that are out there. So we'll start out with just kind of a brief talk. I'll run through some things and then we'll have some time at the end for some questions and answers that y'all submit. So for knee replacement specifically, knee replacement is the definitive treatment for end-stage arthritis of the knee. Now, what that means is arthritis is the wearing down of the cartilage of the knee. The cartilage is the protective cushion on the ends of our bones. And as we age, it naturally wears down. Some folks, it wears down faster than others. A big component of that is genetics. That's probably the biggest reason for developing arthritis. So a lot of times you can thank your mom and dad for your painful knees or hips because you probably got them from them. Other things like injuries can also speed up that, especially if you tore your ACL earlier in life. That's one that can really lead to more rapid progression of arthritis. And so once that protective cushion is gone, we can't really regrow that cartilage. We tried lots of different things, especially in older populations. Now, in young patients who have a maybe focal isolated defect, that's a different story. But in your typical patient with arthritis, we can't regrow it. And so we treat the arthritis, we treat the symptoms of it. We treat it with things like NSAIDs, like ibuprofen or naproxen, things like Tylenol. They can help with pain. You can do injections in the knee. You can try things like cortisone or steroid injections. You can try hyaluronic acid injections, a bunch of different brands of those. Things like PRP or platelet-rich plasma you can inject in the knee. We've tried all these things, and these just treat the symptoms of arthritis. But once you've done all those things and it's not giving you the pain relief you're looking for, or your knee or hip is still impacting your quality of life enough that you can't be as active as you want to be, or you're having to give up things that you like to do in life, then we start to talk about knee replacement, because that's the only way to definitively treat the arthritis. And by, we don't regrow the cartilage, we just cut it out and then replace it with metal and plastic. Probably, again, one of the most in vogue things that patients ask about over the past couple of years has been this kind of, patients ask me all the time, what's this newer way of doing a knee? And really what they're getting at it are muscle sparing techniques with what's called a Subvastus approach to knee replacement. This is not new. I think this was first described about 100 years ago. But the application of knee replacement really kind of came about around 1990, started to begin used in knee replacement settings. And so what that means is, in compared to like a, kind of more traditional, the traditional workhorse approach for knee replacement has been the medial parapatellar approach. So in a medial parapatellar, there's a knee model here. This is the thigh up here in the quadriceps muscle. We come up here around the patellar tendon and we come up and cut the quadriceps muscle and line the tendon in line with its fibers to divide the muscle to get access to the knee. Once we've gotten through the soft tissues, we can get down to the bone and do our work. And in a Subvastus approach, when we come up here, rather than come up and divide the muscle, we come around this muscle here. This is called the vastus medialis. So the vastus, and we go beneath it. So Subvastus. And then we mobilize the whole quadriceps unit as one out of the way to do the surgery. We move it back over once we finish the knee replacement. This is one thing I tell you, this is still a knee replacement. We're still cutting your bones. Doesn't mean it's easy to have a knee be a Subvastus approach, but it is muscle sparing and it can preserve some early quad function, provide a little strength because the muscle doesn't have to heal back. Depends on what studies you read or who you talk to, how much of effect you think that has. I certainly, I'm a big proponent of it and believe that it's helped my patients. And I have a number of colleagues, both partners here in Richmond who do it, or colleagues, surgeons around the country who do it and feel that they've seen it improve their patient outcomes as well. You certainly don't have to have a knee done via Subvastus approach, but if it's something you're interested in, there are a number of, if you go online, there's a number of surgeons across the country who've trademarked different names, what they call their knee replacement. Seems very common to do these days, but I prefer to just take the approach of calling it what it is, the medical term, which is the Subvastus approach, And it's become much more common now. And so, this is something that really in your market, you probably have surgeons who are doing this. Here in Richmond, you certainly do not have to leave Richmond to have any number of surgeons do a knee replacement for you via a muscle-sparing Subvastus approach. And so it has gained popularity. A lot of that, we're in 2026 now that people have the internet, they have more information at their hands, and so there's more research going on, and patients want these things. And if what I tell you is that it's your knee, and if you have to be comfortable with the idea of having a knee replacement, you need to be comfortable with your surgeon, and then comfortable with the approach that they're going to use. If you want it done a certain way, and it's a reasonable way to do it, you can find somebody who can do it that way for you. So I think it's just important to we just call these things what they are. This is just a surgical approach. It's been described. Doesn't need any gimmicky names ascribed to it. It's a muscle-sparing Subvastus approach. And again, first described, I think, about almost 100 years ago. So it's been around a while, but it is more popular. So it's not new. It's just more popular than it used to be. So from the approach side of things, once we get down to the knee, to the bones, to do the actual surgery, we have our traditional kind of total knee replacement. That's far and away the most common. We talk about knee replacement in the United States and in the world. And what that means is that we resurface all three major compartments of the knee: the medial, which is the inside, the lateral, and the patellofemoral, which is behind the kneecap. So that's what this looks like right here. So we've got our thigh bone, our femur here, shin bone here. And then basically we're putting metal all the way across, and a piece of plastic here in between. It's a fancy plastic called polyethylene. And so the new knee moves like that. And we still preserve, most of the major ligaments. We have to take the ACL when we do that, and then you can take the PCL. It doesn't really make much of a difference. And so we're resurfacing the entirety of the joint surface when we do a total knee replacement. The other type of knee replacement I wanted to bring up today is not as common, not as well known, as a partial knee replacement, which can be a very good option for you. A partial knee replacement is where we only replace one of the compartments of the knee. And so most commonly, that's going to be the inside or medial portion of the knee. And really the medical term is a medial unicompartmental arthroplasty, but we'll call it a partial knee replacement. And so what that looks like is this right here, so a little whited out on the screen, but so you can see the only metal we put in is on the inside portion. Metal here, metal there, plastic between. You get to leave the rest of the knee alone. These patients have good cartilage everywhere else. And we get to leave all of their ligaments intact, including their ACL. And so that's one of the big differences here is that it's a more minimally invasive surgery. We don't have to have as much of an extensive exposure to do the surgery, and we get to preserve more of the soft tissues. So, why would you ever consider having a partial knee replacement instead of a total? A couple reasons for that would be if you have arthritis that is isolated to a single compartment and you really only hurt from that spot. We don't have to throw the whole knee, out in the garbage. We can just replace the problematic area, do a surgery that's a little less invasive and has a quicker recovery and isn't as painful. Some other benefits to it: we preserve the ACL, the anterior cruciate ligament. There are proprioceptive fibers in the ACL that provide a more natural sense of motion in the knee with certain activities, especially cutting, pivoting things. So my tennis players, pickleball, people who still want to jog and be active, it can be a very good option that provides them with a knee that feels more natural. Especially in younger patients, if you're in your early 50s, but you've got a bad medial compartment, a total knee is a big surgery. And we know that younger folks have lower satisfaction with total knee replacements than older folks. Again, the average demographic for a total knee is going to be between 65 and 75. So especially patients in their 50s may not be as happy with total knees as older patients. And so that activity level can be aided with a partial knee. One of the historic knocks on partial knee replacements is that they wouldn't last as long. And that certainly was true. If you look back at data sets, part of the reasons for that would be that it's a little more technically demanding to do the surgery well because it is more precise. It's truly just a resurfacing procedure. But with the advent of robotics and applying those to partial knee replacement, we have good evidence now that we're preserving the longevity of these implants. The Australian registry in particular has really shown that the longevity of a robotic assisted partial knee replacement is approaching that of total knee replacement. So anytime we do one of these, we hope it to be 20 years or more, but there are slightly higher failure rates from a partial to a total. Now, again, one caveat to that is when it's a lot easier to convert a partial to a total than it is to revise a total knee. So there's a little bit of bias built into that. But other patients who can be good candidates for partial knee replacements are patients who have kind of moderate or sometimes even mild arthritis of the medial compartment, but they also have a pretty significant meniscus tear. The meniscus is a different type of cartilage that sits in the knee. It's like a shock absorber that sits in there. And you can have tears of that meniscus. And some of these repairs aren't fixable. You can take them out, but taking out part of the cushion can lead to more rapid progression of arthritis in that compartment. Then other types of tears, like specifically a meniscal root tear, which is kind of a bad actor, a tear that's in the back part of that, where it detaches from the tibia. Those patients, especially once you start getting above 50 and certainly into your 60s, with a root tear, we know the success rates with either repair or if a meniscectomy taking out are not very good in terms of patients having sustained pain relief with treating those. And especially if they have arthritis in addition to that root tear. And so you may be a person who just has a mild or moderately arthritic knee, but with a pretty significant meniscal root tear. And a lot of times the better long-term option is to do a partial knee replacement. We can take care of both the meniscus and the cartilage, but preserve the rest of your knee. We don't need a total knee is a really big hammer to swing at that problem for patients, whereas the partial can kind of do it in a more finessed manner and get them back to tennis, get them back to doing what they want to do at that activity level. So, I think partial knee is a good option for patients. We also need to be very selective in who we choose to do these on. You can't have arthritis in the other compartments. They need to look really good. And then you also need to have pain that really fits the pattern of arthritis you have, which again, traditionally, the vast majority of partials are the medial compartment, the inside of the knee. And so you need to have that arthritis pattern that matches your pain, and then you can be a really good candidate for it. The total knee is kind of the gold standard for arthritis, and it's a good option as well, but it is a tougher recovery. We're cutting away more bone, and then really to put the parts in, we do have to move things further out of the way, and it's going to create a more systemic inflammatory response, and it's going to swell more. There's just more trauma to put in these parts. So it is a slower recovery with a total knee than a partial. And in certain patients who, again, meet the criteria for a partial is a good option. It's not something I think we need to be, it can be a very good option that can help you get back to what you want to do in a nice finessed manner. So, long story short, for arthritis of the knee is that once you've done everything, your NSAIDs, your ibuprofen, done your shots, and you just can't get back to the quality of life that you're looking for, the activity level, there's only one true way to fix it. That's with replacement. And then how we do that is evolving. We have technology we use to do these now. Not every surgeon uses them, but again, some of us do. We feel like it helps us be more precise. And so we've evolved the way we're doing them. And then also our surgical approach, like I discussed with the Subvastus muscle sparing approach. If it's something you're interested in, then we have multiple surgeons across Richmond and across the state who perform knee replacements via a Subvastus approach. Not everybody's a candidate for a Subvastus approach. Some knees are too stiff or have too much deformity for the surgeon to be comfortable to do this. But I would argue that most patients are candidates. It's pretty rare when I encounter someone who's not. But again, that's going to be surgeon specific. And so I think just wanted to, with this talk, kind of bring to light that, muscle sparing knee replacement, OrthoVirginia, we have it here in Richmond, other parts across the state. You don't have to leave the area. We can get you a muscle sparing knee replacement if that's what you need, or talk to you about your options. And then the partial knee is also can be done via muscle sparing approach or traditional medial-parapatellar, just like the total knee. So I think I pretty much kind of covered everything I was going to come to today. So I think at this point, we'll go ahead and kick it over to some questions and answers here. So first question, are robotic assisted tools used during partial or full knee replacements? So The answer is they can be. We have robotic platforms for both partial and total. It's kind of surgeon choice if they utilize them or not. It's much more common than it used to be to use technology in the operating room. And it's surgeon specific choice on if they choose to do it. Personally, I do all my knee replacements with a robot. And that's kind of tend to how we're going now, is most people either use the robot for everything or don't and use traditional manual instrumentation. You can have a good knee replacement, whether you use manual or robotics. Again, my personal preference is robotics because I can do things to really kind of sub-millimeter accuracy, which I'm not that good without a robot really. It's more accurate than I am, and I feel like accuracy is key. All right. Do you decide if I do Subvastus or do I? So is the surgeon or the patient the choosing person? So ultimately, I mean, it's the surgeon because, again, not every surgeon does the approach. And then every surgeon is going to have different levels of complexity that they're comfortable doing a Subvastus approach on. I will still say that even though I'm a Subvastus surgeon, that the workhorse approach for knee replacement, the most utilitarian approach, is a medial parapatellar. Your exposure is better. And so the vast majority of my patients, I do a Subvastus approach on. But if I have someone with severely restricted range of motion or major hardware or deformity that I need to contend with, then I'm going to do the approach that allows me to do that knee most safely for that patient. And so, again, that threshold is going to be different based on surgeon. And so I would tell you that you, as a patient, if you want a muscle-sparing knee replacement, you can probably find someone to do it. Now, again, you may be a candidate where it's not the best idea, where we could create big issues. You could avulse a patellar tendon, which is a big problem in a knee replacement. And at that point, the risk benefit was certainly not worth it if that's the result. So ultimately, it's a decision between you and your surgeon. But I think your surgeon should be able to give you that opinion in clinic, to be honest, before you sign up for surgery. So the next one here is the knee replacement outpatient or stay in the hospital. So we have moved over the last several years more and more towards outpatient joint replacement. We know this has been shown very clearly kind of in literature and studies that patients do better when they go home earlier. Staying a night in the hospital really, in the absence of medical necessity for it, really does not confer a lot of benefit to patients. And patients who go home, and there's a little bias in this, I will say selection bias, but patients who go home recover faster than patients who stay in the hospital. Not everybody, can go home medically. Some patients, I don't want to go home. I want to watch them overnight. But the majority of people walking around are outpatient candidates. There's going to be some comfort level that the patient has to get used to the idea. But in reality, even if you're having an outpatient surgery, you're going to get up, you're going to work with therapy. They're going to show you how to safely mobilize after surgery, and they're going to get you home that day. Here at OrthoVirginia, we've got multiple outpatient joint centers where we've really, we've set up a system in place where we are designing it for the patient experience to have a good, successful outpatient surgery. And so, that's our mission, is to let the patient get in and get out and be home, where they're not hooked up to IVs, they're not having bed alarms go up, they can go to the bathroom when they want to, they don't have to wait on a nurse to take them, that kind of stuff. That being said, again, not everybody's a candidate. Some people aren't healthy enough. And that just is what it is. We need to be safe in that regard. Next one here. Is there any age restriction on having a Subvastus knee replacement? Sure, I'd say that's no. Age doesn't really come into the issue on surgical approach. Knee replacement in general, like earlier I said that the knee replacements, on average 65 to 75 is the age, but definitely patients in their 80s. As we get older, there are fewer patients who are, appropriate candidates for surgeries because health issues become more of an issue. I think the oldest person I've done a knee replacement on was 90 years old, and she did fantastic. And so, age, what I tell patients in clinic, age is just a number. you can have an 85-year-old who's healthy as a horse and active, and you can have a 55-year-old who is very unhealthy. So age is just a number, but it doesn't impact the surgical approach. Can I still get a partial knee replacement if I have osteoporosis? Now, this is a good question, actually, because one of the ways of, a partial knee replacement, if you think about a foundation on a house, it's a smaller foundation that we're building on here because we're only on half the knee instead of the full knee. So in patients with really soft bone, partial is probably not a good idea, at least in my opinion, because we do have a better chance of that implant subsiding. We cement it into place, but if that bone's too soft, it could sink down into it. And so in my personal practice, if somebody has just osteoporosis, necessarily doesn't mean they're not a candidate, but if their bone quality is pretty poor, I'm more inclined to do a bigger foundation to really build that house up more firmly. And that's kind of my personal belief on that. And, osteoporosis itself is not a contraindication to having knee replacement. You can cement these parts into place. They're rock solid from the get-go. But in my personal belief, if somebody's got really soft bone, I'm going to do a total knee because I want them to have a better foundation for their house. Can you sign up for a Subvastus but end up having to have a traditional knee replacement? I personally believe that this should be made clear to the patient in clinic before the operating room. I don't think this should be a intra-op decision, just so you know what you're getting. Because, in clinic, we can examine you and see what the range of motion is. We have your x-rays. We have all the information we really need ahead of us in the clinic space. So I think that for me, that's laid out ahead of time. Again, maybe some surgeons feel like until they assess the knee with the patient asleep or under a spinal anesthesia on the table, they can't accurately say. But and the other reality is once you've done a Subvastus approach, you really can't go do a medial carpatellar, or else you could really detach the VMO. So that would be a bad thing. So, different surgeons may do things differently, but in my opinion, that's something that's addressed before the surgery. Is my recovery much different for a partial and a total? I would say yes. I would say the partial knee replacement is going to have a faster recovery than a total. It's less soft tissue trauma. We don't have to sublux or really dislocate. The reality when we're putting the parts in to get a total knee replacement, we've got to, dislocate the knee this much to get the tibial component down into the tibia. So, that's a pretty big trauma to the knee to have to do that. We have to do it. In a partial, we don't have to do that. It's really a minimal. You really don't sublux the knee at all to put the parts in. So I think there's that. Overall, less soft tissue trauma. So it is a faster recovery, less time needing unassisted device, faster return to activity, and just generally less swelling soft tissue trauma. It doesn't mean there's no pain or it's painless, but it's a significantly easier recovery. What if I need both knees done? I get asked this all the time as well. So again, this is going to be a matter of opinion for different surgeons. But we do know, and this is shown in literature, multiple studies backing this, that if we do two knees at the same time, the chance of something bad happening, whether that is a blood clot or poor motion, arthrofibrosis after knee replacement, is going to be higher if we do two knees at the same time than one at a time. There are certain instances, especially in patients with bilateral, both knee severe deformity, where you may consider doing them at the same time. But I tell patients you can recover a lot better if you have one thing to focus on instead of two. So if you have to try to rehab two knees at once, you're less likely to have a good outcome on one of those knees. And so I personally, again, this is surgeon preference, in patients who are interested in bilateral at the same time, I'll suggest that we do it in a staged bilateral fashion, meaning we can come back and do the other side pretty quickly if you're doing well. Done them as quickly as 2 or 3 weeks apart in certain patients. It's pretty rare, but I have done it. And so if a patient's really cruising along at 2 weeks and they're ready to go, we can do their other side quickly. But it's at least twice as hard to do 2 knees at once. We know you have a better chance of something bad happening. And so that risk is not really worth the reward of, I know there's time out of work and recovery and going through it twice, but focus on one thing at a time, get it right would be my mentality. Is a nerve block given? And if so, how long does it last? So this is going to be very dependent based on where you have your knee replacements. Different centers have different protocols, how they do it. My personal approach, and again, here in Richmond at our surgery centers, we all have the same protocol and policy where the patient gets a pre-op nerve block in the pre-op area and then has the surgery. Different types of nerve blocks, there's nerves you can hit. Now with the knee, we need to preserve your motor function. You have to be able to walk on this thing. So we can't numb up your whole leg where you don't feel anything, or else you can't walk. We have some very talented anesthesiologists who we work with who are very good at what's called a geniculate nerve block, but really they're targeting like 5 nerves around the knee that are just purely sensory, and they do a really good job with pain control. The standard medicines you use typically last, 12 to 24 hours. There are newer medicines that we use as well that can preserve the increase the duration of that block up to even 3 or 4 days with liposomal bupivacaine. And so we do use that at our surgery centers. And it can be, it can definitely be, doesn't mean no pain, right? You're going to be in pain after surgery, but it can decrease that pain for the first few days. All right. Can you still use this procedure to redo or fix previous knee replacements? So generally, I would tell you that very few, if any, surgeons, who, even if they do a lot of subvastus, are doing true full revision knees via a subvastus approach. The reason for that is the exposure. And honestly, the name of the game in a revision knee replacement, which is the redo, is exposure. That to me, that's the single most important part of a revision. And so I'm not going to sacrifice that for revising a total knee. I actually do all my, if I have a patient who's had a failed partial knee, whether for arthritis or the implant failed or some, I do those via subvastus approach. And that's a much easier revision than a true total knee revision, which again, I think the vast majority of surgeons do not do a subvastus revision knee. There are probably some who do, but again, with the mantra being, they've already had one messed up knee, we need this to be perfect, I need the exposure I need, I'm going to do what I have to do. All right, well, I still need to do physical therapy after a subvastus knee replacement. Yes, physical therapy is immensely important after a knee replacement. Now, when you start, that varies based on different protocols, but again, what I tell patients is I personally, a knee replacement is not easy. I personally believe that it could be a little easier by doing things certain ways, but it's not easy. You still got therapy. You still have to work to get the motion. If you just sit around and do nothing, your knee's going to be stiff and it's not going to work. You've got to do that work. I tell patients all the time, I have the easy job. I do the surgery. You've got the hard job, which is the recovery. All right. What is the average recovery time? $1 million question here, because this is something that varies widely and based on your goals. The early recovery is getting off a walker or crutches to getting off a cane and walking independently. That can be as short as a week. Sometimes it can be 2 or 3 weeks. Then the points where you don't have any real significant pain can be a couple, that varies based on the patient. I tell you, full recovery is going to take you a year. Most patients, by the time they're a couple months out, feel good and are doing everything they want to do. I'd say my average golfer is golfing 2 to 3 months after surgery. Things like tennis, more physically demanding, are going to take longer to get to. So it's all about your goals and expectations. But in terms of getting around on your own 2 feet out of the house, you can do that in as little as 2 weeks. All right. So thanks for tuning in, everybody. I hope we got something out of this today, and be on the lookout for more Facebook Lives from OrthoVirginia. Come see us. We got offices all across Richmond, all across the state, and we'll be happy to take care of you. Thanks for tuning in.